Hello, everyone. Thank you for being here. It's an honor and pleasure to host this session with a remarkable speaker, Dr. Muna Islami, and my partner in crime in moderating this session, Dr. Omar Al-Zubayr. My name is Mireille Karabetian, and we will be hosting today's session. It will be about parenteral nutrition, how to prescribe it during critical care settings, a very important topic where a lot in healthcare, we say first to no harm. There's a lot of harm can happen if not correctly prescribed, and otherwise total parenteral nutrition can promise a lot of hope for a lot of patients that don't have any other way of feeding. I would like to welcome Dr. Muna and Dr. Omar by introducing who they are. Dr. Muna Islami is a consultant clinical pharmacist in parenteral nutrition, supervisor in King Faisal Specialist Hospital in Jeddah, Saudi Arabia. Recently, she was appointed as a program director for pharmacy specialty parenteral nutrition in the Western region of Saudi Arabia. And my partner in moderating, Dr. Omar Al-Zubayr, consultant cardiologist, consultant cardiology clinical pharmacist, head of clinical pharmacy unit in King Fahd Military Medical Complex in Dhahran, Saudi Arabia. With no further ado, Dr. Muna, if you can start the lecture, and later on we will moderate the questions, Dr. Omar and I, and hopefully this will be a fruitful session for all the attendees. Thank you. Dr. Muna, the floor is yours.
Thank you, Dr. Murray, for the nice introduction. So today we're gonna present mastering a parenteral nutrition prescription in a critical settings. So nothing to disclose, and there's no conflict of interest. We're here just to share knowledge and to share the information and experience. By the end of this webinar, you will be able to identify the appropriate indication of parenteral nutrition, when to start and who the patient is eligible for parenteral nutrition, and when to establish the proper timing of the initiation of the parenteral nutrition, how to formulate a parenteral nutrition prescription tailored to the patient's needs. So we'll go through background of malnutrition and how to do the assessment for malnutrition, and we'll touch base on parenteral nutrition fundamentals, and then we're gonna apply all the knowledge that we share through this webinar by a case discussion. So we'll have an interactive session today. So we'll solve this case presentation step by step. Here are the abbreviations that I'm going to use through this presentation. So I would like to ask you to familiarize yourself with these abbreviations. And if you can take a picture or screen capture of this abbreviation, so in case it's not identified on the slide, so you can be aware of these abbreviations. So I'll just give you a second to take a screen capture of this abbreviation. A large survey has been done in a critical care setting to audit the feeding regimen, and they found three major findings: that the enteral feeding it provide a hypocaloric pattern, and it generate this hypocaloric pattern. It generates an energy deficit. What we mean by energy deficit, that the patient metabolic energy requirements is far exceed the nutrition energy that they received from the enteral feeding. And many studies reported that there's an association of providing an hypocaloric or energy deficit with increased complication rate in those type of population in the critical care settings. And there's a huge number of patients who's intolerance to enteral feeding due to GI intolerance, correlated with the poor clinical outcomes, maybe due to GI ischemia or GI bleeding during the ICU stay. So here the patterns, all the recommendation, the European and the American recommendation, they recommend the enteral feeding as the first choice for feeding route in ICU patients. However, the enteral nutrition alone is often unable to fully meet the patient nutritional needs, which is resulting in energy deficit, which is associated with worsening the clinical outcomes. And on the other hand, if we're going to use the parental nutrition with inappropriate indication, is associated with risk of overfeeding, hyperglycemia, and it promote infection, hepatic steatosis, liver disease, hypoglycemia in case of high insulin doses has been given, and it cause mortality. So, the recent prospective randomized RCT trials indicate that the administration of parental nutrition to supplement or to bridge this insufficiency and energy deficit of this enteral feeding would be within the first 4 days post-admission for the ICU patient who failed to have or to reach the targets with the enteral feeding alone, or the patient is simply contraindicated for having enteral feeding, could improve the clinical outcomes. So the safe use of enteral parental nutrition alone, it can be used alone in case of enteral feeding is contraindicated in case of GI blockage or GI bleeding. With a safe use, with avoiding the overfeeding and hyperglycemia, it's going to be optimal to optimize the patient nutrition support and help the patient and improve mortality. So how to screen those patients with the malnutrition in ICU patients? Simply by using the validated tools, scores, which is recommended by the European Society, the ESPEN guidelines, either the Nutric score or NRS. So how you know your patient is nutritionally at risk if the NRS is more than 3, and if the patient is high risk for malnutrition, if the NRS is more than 5 or Nutric score is 5 and more. So the patient probably needed an extra care for nutrition support and artificial nutrition care. So our aim of nutrition care is to reverse the underfeeding, which is going to lead to increased hospital length of stay, increase the incidence of complications such as infection and organ failure, increase the risk of mortality, and at the same time, avoiding the overfeeding, which accompanied by hyperglycemia, hypertriglyceridemia, hepatic steatosis, and azotemia, hypercapnia, and increased rate of mortality. So you have to give a balanced nutrition support for those patients. So you have to be in between. The objective of nutrition in ICU patient is to maintain a muscle mass, maintain immune function, prevent metabolic complications. So what is parenteral nutrition? It's a method of providing complete nutrition support intravenously, bypassing the GI tract. The PN is indicated when the GI tract is non-functional, inaccessible, or unable to adequately absorb the nutrients required to meet the patient's metabolic needs. What is the goal for the parenteral nutrition in critically ill patient is correcting and maintaining energy, protein, and micronutrients requirement, supporting immune function and wound healing, reversing catabolism, and preventing the associated complications. So who gets the parenteral nutrition? So when the parenteral nutrition is indicated, the general rule for providing or administering the parenteral nutrition in ICU patients, you use the parenteral nutrition if the patient is hemodynamically stabilized patients. So it's contraindicated to use the parenteral nutrition in patient who's hemodynamically unstabilized, especially in the first hours of ICU or the first day of ICU admission. Because if the patient is hemodynamically unstable, so the patient will not get the benefit of the parenteral nutrition, and it may worsen the patient condition by causing refeeding, and it's causing a negative suppression of the immunity. And the parental nutrition, it's usually start at day, there's a debatable for the initiation, we'll go through it. Usually in the post, in the first 4 days, if the enteral feeding is failed to provide the full nutrition requirements, or if the enteral feeding is contraindicated within the 48 hours post-admission in case of GI occlusion, mesenteric ischemia, active GI bleeding. So what's the most common situation? We use the parenteral nutrition. If there's a GI occlusion, functional or mechanical, in case of mesenteric ischemia, intestinal insufficiency, short bowel syndrome, radiation enteritis, or IPD in case of acute phase, or high output fistula, more than 2 liters over the 24 hours. What is the potential clinical situation for using the supplemental parenteral nutrition? If you are reluctant to increase the enteral nutrition due to concern about the possible complications, so you cannot advance the rate of enteral feeding because of side effects, or you're concerned of having complications, or there's insufficiency of providing energy and protein less than 60 or 70% via oral or enteral route for the first days, for first week of ICU admissions, and fail to reach the established energy target by the ICU day 4 despite the adequate attempts to feed via enteral feeding, either gastric or post-pyrotic, you fail to reach the target by the enteral feeding, or in case the patient is hypercatabolism, they need more energy. In case of patients is burn patient or cardiac patients, not meeting the energy and protein targets. So what's the proper timing of for parental nutrition? The American guidelines, the Aspen guidelines, 2022, they recommended to establish initiate the thinking of parental nutrition initiation if the patient is failed to have the full requirements with the enteral feeding within the first week of ICU. And they found there is no difference if you postpone the initiation of that parental nutrition in the first week. And the European guidelines, they recommended to establish the nutrition support, either enteral or parenteral, and they recommend for case-by-case discussion within the 48 hours. This is what we mean by early parenteral nutrition. In case of the patient failed to have the full requirements by enteral feeding, so you will establish a supplemental parenteral nutrition, or in case it's contraindicated, so you will have the exclusive parenteral nutrition. And the RCTs, all the RCTs, the landmark trials like EPANIC trial and caloric trial, they recommend the early parenteral nutrition. They defined it by day 4 or more. So the mean average for starting or consider starting parenteral nutrition from all these guidelines and trials by day 3 or day 4. We have 2 types of parenteral nutrition: exclusive parenteral nutrition. All nutrients needed are covered by intravenous way without any significant enteral intake. Supplemental, if the patient receives some of his energy from 2 feedings, and the rest will be infused parenterally. The component of the parenteral nutrition is macronutrients, amino acid, dextrose, lipid emulsions, and water. Micronutrients, electrolyte with a different salt, and additives like multivitamins, trace elements, additional vitamins and minerals, medications, and additives. So here the electrolytes we're providing through the parenteral nutrition bag, either sodium with the 3 main salts, chloride, acetate, and phosphate, potassium, chloride, acetate, and phosphorus. Calcium, we only use calcium gluconate because this is the only compatible calcium with the phosphate in order to reduce the risk of phosphate and calcium precipitation. And we use the magnesium salts as it's the main available in the market as an IV. And chloride, we will have it from the sodium and potassium, as we mentioned earlier, and the acetate as well from sodium and potassium. What about the trace elements? we have the injectable trace element that contains all the minerals that the patient need, like zinc, selenium, copper, manganese, and fluoride. All these has been added within the RDA requirements as per the guidelines and recommendations. And we only add additional to these IV trace elements, only we add zinc additional and selenium additional, because the zinc and selenium will boost the immunity and help with the wound healing. And you may need an additional zinc if the patient have a GI loss, extra GI loss in case of diarrhea, or the patient having ulcers in case of inflammatory bowel disease patients. And selenium, we need it in cases like burn patients, malabsorptive status like short bowel syndrome, and in ICU patient because it will boost the immunity for the patients. And here is a note. If you noticed an elevated bilirubin, or if there is a obstruction to the bile tree, you will remove the trace elements from the parenteral nutrition bag because the copper and manganese is exclusively excreted through the bile. So you're going to prevent the copper and manganese toxicity. The lipid emulsion, here's all the lipid emulsion approved in the US market. We have the first generation. The first lipid emulsion has been invented in the 60s. It's a pure omega-6. It's only soybean-based lipid emulsion. It's like intralipid or neutralipid. This is the first generation. The problem with the first generation, they noticed that an elevation of liver enzymes and transaminitis, although they provide the full requirement of essential fatty acid to the patient. But it has high risk of transaminitis, and it's a positive inflammatory marker. The second generation, which is a mixed oil, the concept of the mixed oil has been invented in the market within the 70s. Once they noticed that there's an elevation with the first generation of lipid emulsion, so they invent a mixed oil mixed of omega-6, the essential fatty acid, the soybean, mixed with omega-9, the olive oil. And they found it's going to provide the patient with all the essential fatty acid at the same time, the omega-9, it has a pro-inflammatory features, so it will decrease. It has a less transaminitis side effects rather than the first generation. The third generation is a SMUF lipid. It's a mix of soybean, the omega-6, medium chain triglyceride, olive oil, fish oil, the omega-3. And here, the third generation, it has essential fatty acid, and at the same time, it has the anti-inflammatory feature, which is omega-3 and omega-9. So it's proven for the risk of decreasing the risk of infection and decrease the risk of inflammation and decrease the transaminitis as well. The fourth generation, which is the newest lipid emulsion introduced in the market, the Omega-1. Omega-1, it's a pure fish oil. It's only provide omega-3, but and it's proven by the FDA to treat the parenteral nutrition induced liver injury. But this omega-3, it's not the omega-3, the first generation, the fourth generation. It doesn't provide the essential fatty acid for the patients. So you cannot use it alone. For the omega-1, you need to have another source of lipid emulsion to provide the essential fatty acid for the patient in order to prevent the essential fatty acid deficiency if the patient is not receive an omega-6 for 7 days or more. What about in our area, in the Saudi market, we only have two sources of lipid emulsions. We have the lipofundin. It's a mix of omega-6 and medium chain triglyceride. And we have the SMUF lipid. It has omega-6, the soybean, the MCT, medium chain triglyceride, and olive oil, the omega-9, and omega-3 fish oil. So, what's the impact of having omega-3 and omega-9 for ICU patients? So, what's the impact of having the SMUF lipid introduced in the market for the ICU patients? They found here in the study the role of omega-9 in sepsis. It's provide essential fatty acid, the adequate nutrition, and it's well tolerated. It has a fewer risk of infection, and it has less liver enzymes elevations. With the omega-3, and its high credibility for reduction in infection risk compared with the soybean, and it decreased the length of stay for the patient versus the soybean. And it has the omega-3, it has pro-inflammatory markers. The parental nutrition preparation, how this parental nutrition bag prepared. There is a multiple way of preparing this parental nutrition. The old way, it's a multi-bottle system. They simply have a separate line of amino acid, lipid, dextrose for the patient. So you will hang all these component for the patient, which involve high risk of infection, and it will give inaccurate dosing for the patient. The multi-chamber parenteral nutrition bag, the ready-made, ready to use, or the multi-chamber bag, it's a standardized way of formulation that is compounded by the company, ready to use. So it saves cost and time at the same time and decrease the risk of infection. And the customized parenteral nutrition bag, it's prepared by the pharmacy, automated by the automated compounder, and it's tailored to the patient's needs. And we cannot have only the multi-chamber bag in the institution, or we can, and at the same time, we need to have a parallel use of the multi-chamber and the customized parenteral nutrition bag at the same time. Because the multi-chamber, one size does not fit all. So it failed to fulfill the whole needs of our population in the hospitalized patient. So you need to have the customized parenteral nutrition bag for the patient who failed to have the multi-chamber in case of hypernatremia, in case of any electrolyte imbalance, or if the patient have an AKI or acute liver injury. So you cannot use the standardized formulation. So you need to tailor the patient's requirement by using the customized parenteral nutrition bags. The administration of parenteral nutrition either by peripheral or central. Peripheral parenteral nutrition, the PPN, it's infused in the small vein, either in the upper or the lower extremities. So you can use the parenteral nutrition immediately at the same time, and it's reverse the catabolism because there is no procedures needed to insert a line, or there is no delay will be there. And but the problem with the parenteral nutrition bag, it will not fulfill the full nutrients need for the patient, and it's only used for a short-term use. What about the central parenteral nutrition? It's infused through the large vein directly to the heart and major circulations. The central parenteral nutrition bag, it's delayed due to gonna wait for the central line insertion, and it's provide the full nutrition needs, and it's more customized to fulfill the fluid and nutrition need at the same time. So what's the criteria for having the parenteral nutrition bag? Who will get the parenteral nutrition, the PPN? If the needs of the patient is for nutrition needs is less than 1,800 kilocalorie per day, and the patient require less than 10 to 14 days, the peripheral venous access is available with a good vein circulation, and there is no fluid restriction because in the PPN you need to have more fluid. You need to infuse 2 liter or 3 liter and more to provide the patient nutrition. And at the same time, you need to have a venoprotectors. What do we mean by venoprotector? Because the main side effects of peripheral parenteral nutrition bag is the irritation and phlebitis. So we need to add a hydrocortisone 5 milligram per 1 liter inside the parenteral nutrition bag to protect our vein from the irritation of this parenteral nutrition. Why the parenteral nutrition is causing irritation in these small veins? Because it's highly a high osmolar bag, and it has more than 13 nutrients. So you need to protect your vein, your small vein, and give hydrocortisone as anti-inflammatory as protection, 5 milligram of a steroid per 1 liter inside the parenteral nutrition bag, and heparin, zero point 0.5 unit per 1 ml. And the heparin addition, it's debatable, and it's mainly used for the neonates patients or small age population, pediatric, or patient is very cachectic and they having very small veins. And you need to have a big needle gauge from 18 to 21. So you need to check with your nurse, and you need to inform your primary nurse to infuse this parenteral nutrition bag in a gauge size of needle big, 18 to 21. And the osmolarity, it will be less than 900, depend on the patient population, and sometimes will go up to 1000 or 1200 in neonates. Let's dive into the parenteral nutrition prescription, the macronutrients and micronutrients dosing. The energy for the first week from 12 to 25 kilocalorie per kg, and then after 10 days, you're going to progress to the full feed. The protein intake will be from 1.2 to 2 gram per kg per day. And this is the American guidelines, the Aspen guidelines. The European is more conservative with the protein intake. They recommend to give 1.3 and from 1.3 and then upgrade it to 1.5 for ICU patients, and to give the higher dose of protein for a patient who's in CRRT, or the patient is obese and they need the higher protein dose. The glucose, they recommend to not exceed a glucose infusion rate more than 5 milligram per kg per minute, because the major complication you will see of the parenteral nutrition related in ICU patient is hyperglycemia, because of it's a stress induced by the ICU or by the steroid use for the septic shock, and sometimes for surgical ICU patient, it's a stress induced after surgery. So you need to strict your glucose, the dextrose infusion rate, to be less than 5 milligram per kg per minute, and the lipid to not exceed 1.5 gram per kg per day. And the micronutrients, you will add a trace element and vitamins on a daily basis. The antioxidant use of high dose of monotherapy or combination of vitamins like vitamin C or folic acid or selenium without any proven deficiency is not recommended by the recent European guidelines. And here, it's recommended for ICU patients to decrease the carbohydrate content and increase the intravenous fat emulsion in order to prevent the hyperglycemia. The parenteral nutrition modification for CRRT patient to give extra protein to give extra protein in case of CRRT, because the patient on CRRT, they tend to lose amino acid, and you will give potassium and extra boluses and micronutrients. For ECMO patient, there is a risk of machine troubleshooting with the lipid particles. For AKI, it's recommended to reduce the amino acid electrolyte and renal excreted multivitamins, zinc, and selenium. For liver injury, you will watch for amino acid ammonia level and dextrose and fat emulsions. For diuretic changes, you have to be vigilant. In case of diuretics, the Lasix infusion stopped or decreased, or it shifted from infusion to intermittent. So you need to adjust your potassium based on the diuretic changes. So you have to have a proper communication with your ICU team in regard of diuretic changes. So we need to be cautious with the use of parenteral nutrition. What do we mean by cautious use of parenteral nutrition? You have to have a 3 objective. It has to be fulfilled. The first objective is prevention of overfeeding and hyperglycemia. How to prevent hyperglycemia is by several monitoring from 4 to 6 or 8 hours per day, and to provide insulin. And you work with your clinical pharmacist and ICU team on this. The second objective of cautious use of parenteral nutrition is preventing the overfeeding and parenteral nutrition related liver enzymes. You will monitor the ALT and AST and ALP and bilirubin at the initiation, and then you're gonna at least several times per day, maybe twice or 3 times per week. And the third objective is prevention of free feeding syndrome by monitoring the electrolyte sodium, potassium, phosphate, magnesium, urea, and creatinine through either ABG or VBG or the blood serum levels at the initiation of nutrition support. And in case of patient having a high risk of free feeding, you will monitor it Q4 or Q12 hours in the first initiation of parenteral nutrition. Here's the parental nutrition resources. If you can scan it, here's the Aspen parental nutrition resources, the website, and the I would recommend if you would download the European guidelines app. It's very easy to cross the guidelines through the application, so you'll have the full resources for parental nutrition in case of, and they have lots of information regarding the trace elements and the condition within ICU for parental nutrition. So let's start our case and apply what we have learned from this presentation. Meet Fatma. Fatma is a 51 years old female with a history of systematic lupus patient and lupus nephritis undergoing treatment with azathioprine, prednisolone, and aspirin. She has hypertension and she experienced multiple episodes of diverticulosis requiring surgery, including a recent laparoscopic sigmoidectomy and total abdominal hysterectomy with a bilateral. So she had multiple GI surgery. After the surgery, the patient developed abdominal pain, tachycardia, fever, and they did a CT scan and they found there's an anastomotic leak. As a result, she went for emergency surgery and she had an open surgery involving a procedure and colonoscopy creations. Here's the anthropometric data for the patient. As you can see, her usual weight is 71 kg, her BMI 34, and she's an obese grade 1. She has a PIC line, vascular access, central line. So I would like to hear from you or you can write down in the chat. Do we feed obese patients? What do you think? Or you're gonna say that this patient is obese. It's okay to keep her MPO after her procedures. No need to feed these patients. I just want to have your opinion in the chat. Oh, sorry, the code for the barcode is expired. Apologize for this. I don't know if I am able to see the chat from the attendees.
They're answering Doctora in the Q&A section, and multiple are saying yes, of course we can feed, or yes,
Okay.
we feed. Yeah.
Oh, thank you, Dr. Omar. Okay. So the obese patient in critical care setting, this is an amazing paper from Aspen website. We're going to use it as a reference for our case today. This is a case-based application for obese patient in ICU with a COVID patients. They found that the obese patient in critical care settings, they having a sarcopenia. What do you mean by sarcopenia? loss of muscle mass because of aging and obesity, and because of the ICU stay. Sarcopenia obesity, it's a combination of low skeletal muscle mass coupled with a high obesity. And this high fat mass, it's masking the malnutrition and the sarcopenia. So it's misleading the healthcare provider. And the critical ill patient with sarcopenia obesity may not be viewed as a risk for malnutrition due to higher fat of stores, and there is a stigma and bias associated with obesity. Therefore, these patients may not receive early nutrition support, and they usually dismissed and undermine their nutrition support. So you need to have a care team should view all the patient as an individualized and case by case, and work to overcome any body weight bias among the clinician and family members. And they recommend a high protein, hypocaloric diet. Why they recommend a high protein for these obese patients? To reverse the lean body mass that they miss with the aging and with an ICU stay, and mobilize this adipose stores by providing hypocaloric feeding and minimize the metabolic complications of overfeeding. The goal for feeding an obese patient in ICU is to support the lean body mass, promote anabolism and positive nitrogen balance, avoid overfeeding and worsening of comorbidities such as hyperglycemia, increased CO2 production, and fluid overload, promote hyperglycemic control and wound healing, include an exercise program, early mobility or physical activity approaches to optimize the lean muscle mass. So what do we mean by hypocaloric feeding? For all cases of obesity, the energy intake should not exceed 65 to 70% of target energy requirements if you have the indirect calorimetry in your institution. If you don't have the indirect calorimetry, you can use the weight-based equation. If your patient BMI is within 30 to 50, you can use the energy from 11 to 14 kilocalorie per kg with actual body weight. Or if your patient is more than 50, the BMI, so you can use from 20 to 25 kilocalorie per kg ideal body weight per day. So the energy need for Fatima, our patient, her BMI is 34. This is an obese grade 1. So the target will be from 11 to 14 kilocalorie per kg per actual body weight. So how to get this energy? By multiplying the 14 with her weight, the 71, because you're going to use the actual body weight, and you will have an approximate 1,000 kilocalorie per day. So this is her target as hypocaloric diet. Okay, this is the target. So do we initiate with this target at day 1 for this patient? What do you think? I don't know if I'm able to see the Q&A.
I will
Okay.
transfer you
Yeah.
their answers from the Q&A. Yeah.
Thank you, doctor.
One person saying no.
Yeah, Mahalatab is saying no.
Okay.
Two are saying no.
Why we don't give a target from day 1? We mentioned earlier that we are providing a hypocaloric feeding for this patient. So the target here is very low, 11 to 14. So it's depend if the patient is having risk of refeeding. We'll go through it, the risk of refeeding. So you need to check if your patient is having a refeeding risk or not. Here's the Aspen criteria for identifying your patient if they are at risk for refeeding or not. Her BMI is not 16 to 18. So the first one is not in our patients. And the patient was only in PO for 2 days. She's only having low level minimum to moderate electrolytes. I'm going to show you the labs. Here's her labs electrolytes. As you can see, the potassium is only 3.4, which is mildly reduced. And what else? She's having CO2 is low. The phosphorus is 0.73, which is mildly reduced. So she's having moderate risk because even the moderate risk is not fit in our patient because she's only have one criteria. You need to have two criteria. So our patient does not have a refeeding risk here. So you can start with the target in this case, and also the 14 kilocalorie per kg per day. It's an hypocaloric diet, so will not cause refeeding. Here's the prevention criteria from the Aspen. They recommend to initiate dextrose with 100 to 150 gram of dextrose or 10 to 20 kilocalorie per kg for the first 24 hours and advance by 33% of the goal every 1 to 2 days. And to supplement with thiamine, 100 to 200 milligram per day. And they did not recommend any fluid or protein restriction. They recommend a monitoring of electrolyte every 12 hours, and they recommend to supplement the electrolyte before initiation of parenteral nutrition. So it's acceptable to use the target at day 1 for this case. Because I want you to have this this mind of critical thinking. It's a case by case decision. So it's not a rule or by book. You start by 60%. You have to check your patient if they're having refeeding syndrome or no, and then go by the criteria of the prevention. Okay, so let's go to the protein dose for our patient. And as we said, we're going to provide a high protein for our patient. Why are we giving high protein for obese patient? Just to maintain and reserve this lean muscle mass, and to reverse the catabolism and prevent the obesity-related metabolic complications. The protein dosing in obese patient, if the BMI from 30 to 40, to give 2 gram per kg of ideal body weight, and if the BMI is 40 or more, to give a protein 2.5 gram per kg per ideal body weight. Okay, here's the dosing consideration for obese patients. We're going to use adjusted body weight for the rest of the calculation, and we're going to use the ideal for the protein calculations, and we're going to use the actual for energy calculation because our patient BMI is less than 50. So the protein need for Fatima will be 2 gram per kg per ideal body weight. How to calculate the ideal body weight? You just find the height and convert it to meter, and then multiply 22 with the height in meters square. Okay, so now we have the protein dose for Fatima, which is 2 gram per ideal body weight, which is the dose will be 92 gram per day. Okay, what about the calories of this protein? This 92 gram will provide how much calories? I'll just give you a second to calculate the calories of the protein for Fatima. Are you done with your calculation?
Just now they say 368 kilocalorie.
Okay. So 1 gram of amino acid will provide 4 kilocalorie. So you'll just multiply the 92 by 4, will give you 368 kilocalorie. So as we said, we're going to provide the target for the patient, which is 1,000. And you will 1,000 minus 368 will give us a remaining of 632, will provide it from non-protein source. And here is the kidney function of the patient within the normal range. So it's okay to provide a high protein for this patient because the kidney is functioning very well. It's within the normal range. What about the non-protein calorie calculations for Fatima? As we mentioned earlier, because the hyperglycemia is our concern in ICU patients, so they recommended to provide a fat emulsion dose more than the dextrose. So the dose will be higher than the dextrose to prevent the hyperglycemia. So the remaining calories will just to prevent the hyperglycemia in ICU will provide 60% of the remaining calories will be 379 kilocalorie per day. And so we have the calories. Now how are we going to have the volume of the fat emulsions? Each 1 ml of fat emulsion, it gives us 2 kilocalorie. So this calorie, the 379, we will divide it by 2. So how much ml this will provide? I'll just give you seconds to have your calculations.
Uh, 189. Let's say 190. Right?
Yes,
And then
180. Okay, so we're around our calculations. And the infusion hours by the CDC recommendation to prevent the lung infection, to approve the stay will be from 10 to 12 hours. This is the recommendation by CDC to prevent the lung infection. And so the rate will just divide the 180 by 12. So it will give us a rate of 15 ml per hour. So now I want the grams of lipid of fat emulsions. We are using a 20% of fat emulsions, which means 20 grams per 100 ml. So 20 gram per the 180 ml, our volume, then divided by the 100 ml, it will give us 36 grams. This 36, it's 0.7 gram per kg, which is less than 1 gram per kg as per the ASPEN recommendations. What about the lipid infusion hours? How to find the lipid infusion hours? You will divide the total grams of fat emulsions by the adjusted body weight for our patients. As we said, we're going to use the adjusted body weight for all the calculations, for the rest of the calculation, and ideal for the protein and the actual for the energy. Then divided by the 12 hours, it will give us 0.057 gram per kg, which is less than 0.11 gram per kg per hour. Sorry, there's a typo mistake. It's less than 0.11 gram per kg per hour. Okay, which lipid emulsion we're gonna use? Lipofundin or smoff-lipid? I'll just give you a second to think of it, and I'm gonna hear from you guys which lipid emulsion you will use for this patient.
They are saying semaglutide.
Okay. Why we're using semaglutide? Because it showed a decrease in the line infection, and it has pro-inflammatory markers because of the omega-3 and omega-9. So it would decrease the chances of having overfeeding and parenteral nutrition induce liver injury, and it will decrease the mortality in ICU. Here's the liver enzyme profile for Fatima for our patients. So all within the normal ranges. And here's the triglyceride for Fatima, which is within the acceptable range through the whole nutrition support, the parental nutrition support course of therapy. Moving to the dextrose dosing for the patient. So we have a remaining of 272 kilocalorie will provided from the dextrose, and 1 gram of dextrose will provide 3.4 kilocalorie. So 272 divided by 3.4 will give us 80 grams. Then I'm gonna have a dextrose concentration. The volume for the parental nutrition for Fatima, it's 1,500, 1,500 ml. So you will divide the 80 by 1,500 ml, multiply by 100. So you will have a concentration of 5% of dextrose. The glucose infusion rate, how to calculate it? You will divide the total calorie of dextrose by the adjusted body weight for the patient, divided by the total infusion hours, divided by 1 hour. It contains 60 minutes. And then you will multiply by 1,000. It will give you 1.06 milligram per kg per minute. And here's her glucose readings, which is within the acceptable range. What is the target for glucose for patient receiving parenteral nutrition in critical care settings? What do you think? What is the target glycemic recommended goal for the patients? Any answer in the Q&A, Dr. Omar?
I think they're still typing.
Oh, okay.
One answer is like a question. So below 10 millimole, then question mark.
Yes, below 10. This
Yes,
is the
140.
yeah.
Yeah.
Tamam. So this is the final prescription for Fatima. We will provide nutrition of 1,500 ml over 24 hours within the rate of 62.5 ml per hour. And the total calories will be 1,000 kilocal, which is 14 kilocal per actual body weight. It's a hypocaloric feeding, which is on target. The amino acid, we're going to provide a high protein for the patient, 2 gram per ideal body weight, 92 gram. And the lipid emulsion, it's 180 ml over 12 hours with a rate of 15 ml per hour, which is within the recommendation of the aspirin, less than 1 to 1.5 gram per kg. And the dextrose is the 5%. Glucose infusion rate is less than 4, according to the recommendation of aspirin, to prevent the hyperglycemia in the ICU. Okay. On the next day, after we started the parenteral nutrition, the glucose readings started to elevate it. 15, 13.6. And this is probably, it's a parenteral nutrition induced hyperglycemia and surgery and stress induced. So how are we going to manage this? With lots of precautions that we followed, with lots of precaution to prevent this hyperglycemia, because it's happened. So how to manage this hyperglycemia induced by the parenteral nutrition? And it's a multifactorial ICU, surgery, and maybe and steroid as well. Here's the
They're saying
Yes.
Sorry, they're saying using insulin with recommended doses, insulin infusion.
Yes, bravo. Here's a review article for managing hyperglycemia in hospitalized patient receiving parenteral nutrition. They mentioned that in ICU, the European guidelines, the recommended target of blood glucose range from 7.8 to 10, less than 10. And for patients with persistent hyperglycemia, more than 10, to start IV insulin infusion. Why they preferred the insulin infusion? Because it's very easy to adjust and it has a rapid adjustment method for ICU patient. And if the patient is stable patient, they recommend to add directly to the parenteral nutrition bag regular insulin, but you have to consult your hospital pharmacist or the clinical pharmacist to ensure the stability and compatibility and to calculate for you the dose of the regular insulin. What about the ADA recommendation? The ADA guidelines, they recommend 4 approaches for management of hyperglycemia in patients receiving parenteral nutrition. The first approach to use the regular human insulin infusion separately from the parenteral nutrition bag to have an insulin infusion, which is very effective in ICU patients. The approach 2 is to use the subcut insulin with the basal and bolus protocol, which is totally outside the parenteral nutrition. The approach 3 is to have regular insulin added inside the parenteral nutrition along with the sliding scale. And with approach 3, the hypoglycemia will not develop after any interruption of the parenteral nutrition. The approach 4, a combination of subcut insulin with a regular insulin added to the parenteral nutrition. So you add insulin inside the TPN bag and you will have insulin deglutic outside to the patient. So you have 50% inside the TPN and 50% outside the TPN. So this approach 4, it's recently added by the ADA recommendations. What is the difference between the approach 3 and approach 4? The approach 4, when you add 50% of the insulin inside and 50% is outside, the advantage that you have, it's better metabolic outcomes and possible smooth to transition once the parenteral nutrition is stopped. So the advantages of combining the therapy of subcut and adding insulin inside the TPN is better metabolic outcome and smooth transition to the parenteral nutrition upon stopping the therapy. And hypoglycemia risk after interruption of parenteral nutrition is very low when combining the therapy because you're not giving the insulin at once. You're giving 50 to 50%. And here's the summary of the recommendation from the guidelines. The ADA, the recent ADA guidelines, they recommended one of the approaches that we said, approach 3 for stable patients, to add the insulin inside the TPN bag once you have the total requirements of insulin more than 20 units from the sliding scale. So you start to add the regular insulin 1 unit per 10 gram of carbohydrate with the supplemental sliding scale every 4 to 6 hours. And the endocrine society guidelines, they recommend to add the regular insulin to the parenteral nutrition right away. No need to wait for the sliding scale unit over the 24 hours. And the other guidelines, they recommend to start insulin infusion along with the parenteral nutrition. And they may recommend to add the insulin regular inside the TPN. So back to our patients. So we're having 2 options. Either you give insulin infusion because our patient in ICU, or to use the regular insulin added to the parenteral nutrition, or the 4th approach of the ADA. But here our Fatima, our patient, she get transferred to the surgical ICU. So she's now not in ICU settings. So she's stable patient. So I'm going to add a regular dose of insulin inside the TPN as per the Aspen recommendation, 0.1 to 0.2 unit per gram of dextrose. So we'll add 0.1 units. You will multiply it by 80 grams. So you will add 8 units of the insulin inside the parenteral nutrition bag with the insulin correction scale. and you will monitor the point of care every 6 hours. The monitoring recommendations for the recommendation from the Aspen paper for obese patient in a critical care setting, they recommend an additional monitoring to assess the worsening of hyperglycemia, hyperlipidemia, hypercapnia, and fluid overload, and hepatic fat accumulation in obese critical ill patient receiving enteral or parenteral nutrition. Then we're gonna manage the transition out of the ICU. So you have to consult your dietitian for vigorous assessment and intervention for parenteral nutrition tapering off and adequate protein intake, physiotherapy consultation for optimal exercise plan to increase the muscle mass, function, and ambulation. So the take-home message is to prioritize in obese ICU patient, prioritize early adequate protein while avoiding excessive calorie to prevent overfeeding, and to use adjusted or ideal body weight to calculate the parental nutrition needs, guided by the indirect calorimetry when available, and to monitor glucose, triglyceride level function, and fluid balance closely, and adjusting the parental nutrition composition frequently. And here we're ended our webinar, and the floor is open for any questions. If you have, you can
Thank
type.
you very much,
Okay.
Doctor. Thank you very much, Doctora. Great presentation, to be honest. And mashallah, we have a lot of questions. We'll give you a moment to breathe. Dr. Mireille is trying her best to answer these questions. We have a few here that, many questions about how to approach patients with AKI, or liver failure, either hepatitis, transaminitis, or loss of function like hybilirubin and coagulopathy. Will there be any alteration of the proteins of other things? And we have one question about the acceptable level of ammonia increase, and when would that affect your prescribing of the TPN?
Okay. So I will answer the question. If you have transaminitis, the first modification, you will modify your parenteral nutrition prescription. You will just switch the lipid emulsion to omega-3, the SMUF lipid, and you will try to decrease your dextrose less than 4 milligram per kg per minute. And the protein here, the recommendations, if you have an acute liver injury, in case of the acute phase, you will have to have an adequate high protein just to reverse the catabolism. And they defined it in the guidelines, either the American Association for Liver Diseases or the ESPEN guidelines, the European guidelines. They define this high protein as 1.3 gram per kg per day with an extra protein, either from 40 to 60 or 70. But they are not encouraging for high protein doses. Not higher than the 1.7 gram per kg per day. And if you have a high ammonia level, the ammonia level, it's not a definitive indicator for hepatic encephalopathy, but it's one of the indicators, especially of an ICU patient, because you cannot assess the hepatic encephalopathy. So in case of hyperammonia, here we're not saying acute liver injury. Here the scenario, it's hyperammonia. So in case of hyperammonia, for sure you will decrease your amino acid, but you will not decrease it dramatically. You will just decrease the dose, just to keep it from 1.3 to 1.4, which is recommended by the European guidelines. Why we're decreasing the protein? Because the protein, if you see the urea cycle, it's one of the precursor of the urea and ammonia. So when you decrease the protein, you are decreasing the risk for hepatic encephalopathy, and you will decrease the toxins inside the CNS to cross the CNS barrier. So you'll just decrease the amino acid just by small percentage, or you just keep it from 1.3 to 1.5, and you will just monitor the ammonia. And the frequent level of ammonia level is not recommended by the guidelines. And you have to work with your ICU team and consult a hepatology team in this regard. And what about the amino acid formulation? Um, there is an hepatic formulation for patient with a liver injury or patient with a chronic liver injury. This formulation, it's rich with the branched chain amino acid. But unfortunately, we don't have it in Saudi market. I'm not sure if in the Gulf area you have it, but it's recommended to use this formulation, which is the hepatic formulation, because it's rich with the branched chain amino acid, and it's low with the aromatic chain amino acid, which is causing the accumulation of the toxin inside the CNS. So you can check with your company if you have this liver formulation.
Great, thank you, Doctora. We have a question here is if I have an ICU patient. Sorry.
Meanwhile, Dr. Mona, there are people really thanking you for your lecture, and they're very grateful for the informative session that you've led.
Oh, thank you, Dr. Mirai. I will post in the link of the ESPN application for download. Sorry if the barcode is not functioning.
Also, many people asking about the recording, and I just checked with the organizers, and the recording will be sent to everyone.
Okay, perfect. Yes, Doctor.
Apologize for that. It was the overhead announcement. We have the ICU critical care question. If I have a patient, it is difficult for me to determine the weight and height. How would you approach this patient if I want to give parenteral nutrition?
Oh, we had this case back in maybe 2 or 3 years ago. We had a patient. He had multiple amputation because he's diabetic and he has leg amputation. At the same time, the patient have multiple of GI resections, and they had lots of surgery, and we cannot determine his weight. So we had to have like an site observation with our dietitian and an ICU team, just to have a roughly estimation of his weight. I know this is not an accurate, but it's a tough situation because our ICU beds does not have a weighing bed. So maybe if your institution have a weighing bed, it will be helpful for you. But unfortunately, our ICU unit does not have this weighing bed. So we have to go by eyesight and back of his baseline records and asking his family, and just to give approximate weight for this patient for dosing weight.
Great. And I think, would you rather go and tend to go with the low estimation rather than high estimation?
Yeah.
Okay.
We rather go
Also,
with the low estimation.
I've seen some of the experimental stuff using artificial intelligence with smartphones. They can somehow detect either the weight and height. Also, you can ask assistance from your physiotherapy department. Usually, they have special weighing devices for difficult to move patients.
Yes.
We have one question from Kashif Majid. He says, we observe frequent, yes, sorry.
Just for the weight and height. So I posted to some of the people that I'd asked, there is a way to estimate height or actually calculate height from forearm. So the forearm can be measured and then plugged in into a formula. And then for the weight, calf circumference, so the just a calf circumference can be measured and then plugged in into a formula, and then a weight can come out. Definitely better than estimating with an eye because it becomes, even if it has, it's not the perfect measurement, but at least it's an objective measurement that one can use to monitor.
That's great, actually.
Perfect. Thank you, Dr. Miray and Dr. Omar, for your inputs.
Thank you.
Let's get
Um,
very curious with the AI.
Yeah, I've seen the RT use it, the respiratory therapist. So we have one question actually. The question says we observe a frequent multivessel DVT in patients with long-term TPN. So why do we see DVT in those patients, and how can we prevent it?
Yes, the thrombosis, it's one of the complication of the long term of central parenteral nutrition use. Why we have been seeing this? Because most of the population who's been using the parenteral nutrition or receiving parenteral nutrition, they don't they may not move around and there's no ambulations. And one of the reason for thrombosis may be calcium and phosphate precipitation from the formula. So you need to check if your formula is free of calcium and phosphate precipitation, because if you have a huge number of calcium and a huge number of doses of calcium and phosphate, it may accumulate and causing particles inside the bag. And this particle, if you're not using a filter, if you are not using a TPN filter, it will pass through the lines and go to the major circuit and may cause thrombosis and may cause cardiac arrest or respiratory failure. So number one is to use a TPN filter and do not administer any TPN without a filter, because will be considered a crime. Because although if you're checking your calcium and phosphate for each preparation, still you may have a chance of precipitation risk, maybe 0.1 or 0.01. So you need to have like a prevention, the TPN filter. So in case if there's any particle, this filter will not allow any particle to go through the circulation. And to check with your pharmacist to use the DVT prophylaxis, the pharmacological, the enoxaparin or the heparin, and to encourage your patient to mobilize.
No, excellent. We have multiple questions regarding the what type of weight should we use. So if we can revisit that, like adjusted, ideal, or
Yeah, it's kind of debatable. Most of the recommendation, the American and European, they recommend to use the adjusted body weight if you have the indirect calorimetry. But in case you don't have the indirect calorimetry, so they have this weight ratio just to make it easy for you. So they simplified it for the clinician in case they don't have the indirect calorimetry or they don't have the calculation. Here, if you don't have the calorimetry or you don't have the calculations, so they simplified it for you to use the weight-based equation. So in case your BMI, your patient BMI is from 30 to 50, to use the actual body weight, and you will give 11 to 14 kilocalorie per kg. And if your patient is the BMI is more than 50, to use the ideal body weight from 22 to 25 kilocalorie per kg per day.
yeah, this is specific for obese. But I think you showed one slide. You said, yeah, you showed 3 lines, which what you were using.
Here's for the regular patients. That case was for obese patient, but this is for regular ICU patients.
So the protein intake is actual body weight, the energy is actual body weight, and glucose is actual body weight?
Yes, we're using the actual body weight.
Only
If
because
your
Okay.
patient,
normal
if
weight,
you're
actual and ideal are not that far. This is why.
Mm.
Obese, just different weights get used because they have an exaggerated amount of weight, and that doesn't accommodate for what the organs can do. But in normal weights, they're put very close, so actual can be easily used without any harm.
Yes.
yes,
And if I may add, and you correct me, doctor, if the difference between actual and ideal is more than 50%, so in this case, adjusted might be used.
if the actual body weight is more than 120% of the ideal body weight, you will use
Mm.
the adjusted body weight. This is another
So,
definition of obesity.
mm.
Because sometimes you have an overweight patient. Yeah, we have Mireille on board, our dietitian specialist, expert. So sometimes your overweight patient, they come in the gray area. So the BMI will not define the obese well. So you will have the second definition for obesity if your actual body weight is more than the ideal body weight by 120%. So you will use the adjusted body weight. And
120.
yeah, 120% from the ideal body weight.
Okay, thank you. One question about the max TPN infusion rate through central line, not peripheral line.
There is no maximum because the central infusion, it's a larger vein. So you can have maximum infusion, but the maximum per pharmacy preparation, the maximum size for TPN bag, we have a 3 liter. I'm not sure if your institution have more than this, but most of the institution, the TPN bag is 3 liter.
Um, you mentioned different types of lipid emulsions. So we have one question here about MCT oil. Is it available in the market, IV or only orally or enterally?
We don't have a pure MCT IV. It's only
Mm.
oral or enteral.
We have one question about the electrolyte and how to calculate them. And I will add on top of that, when should you consider to go to the maximum limit of electrolyte? Because I know we always prefer and we always are being taught that you should use peripheral lines, separate IV lines to replace or to correct, and use TPN only for the required daily requirements of electrolytes.
Regarding the electrolytes, I did not broach this subject because it's individualized to the patients. Let me share with you the Aspen dosing recommendation. Just give me a second. Because this electrolyte, it's based on on the patients, so it needs a clinical judgment.
Mm. And I think it's always a good practice to use if you need to replace and correct large abnormalities or abnormal electrolytes raising, use different line and use TPN only for the daily requirements, not for correction.
Yeah, I echo Dr. Umar. Mainly the TPN, it's only preferred for nutrition use, not for electrolyte replacement, but we are doing our best to help the patient and receive appropriate electrolytes because you have to have an appropriate dosing for electrolyte because you don't want your team to give extra calcium outside, and this may have risk of precipitation because you have a phosphate inside the TPM bag. So you have to be mindful about this. Here are the recommendations from the Aspen in regard of electrolytes and mineral. For the sodium and potassium, 1 to 2 milliequivalent per kg, and you may need extra if your patient is having diarrhea, vomiting, or any GI loss. And the phosphorus, the dose from 20 to 40 millimole, and you may need extra if your patient is having high dextrose intake or refeeding syndrome. And the acetate and chloride based on the acid-base balance. And the magnesium from 8 to 20 milliequivalent, and the calcium from 10 to 15 milliequivalent. But I just want you to inform you that these units, it's US units. So you have to make sure that your dose or your supplement or electrolyte that you have, it's the same unit you're gonna use.
Excellent.
So
We have a couple of questions about the ready-made TPN. So if I have an obese patient and the ready-made is not 100% tailored to that patient, which of the macronutrients should I utilize? Should I prioritize? Like this macronutrient, I should give 100%. And then a follow-up question: can I add macronutrients ampules, like inject inside the ready-made, or is that a violation of quality assurance and other things?
good questions. Because this multi-chamber, they're ready to use by, it will not fit the whole populations. And your patient, your obese patients, they need a high protein. Um, so you can give an extra. I'll share with you the recommendation by the company. You have to ask your company representative. It's depend on the manufacturer and the brand you're using. They will give you a sample of stability study paper. So they will guide you which how extent you will give extra doses. So let me share with you one of the documents for the product that we're using as a multi-chamber from Baxter company. Just give me a second. My screen is clear. You can see the
Yes.
screen. Okay.
Yes.
Here's the product information. This is the Olimel N9A, the standardized formula. Here's the 1 liter will give you this amount of macronutrients and micronutrients, and the 1,500 will give you this, and the 2 liter will give you this. Moving to the stability here, yeah, here that you can add. Here's the supplement extra doses you add. I'm for I'm back. Can add additional sodium. So it for
I think Dr. Omana is having a connection issues.
Meanwhile, I would like to remind everyone to check the chat because we were able to send the links of the references that Dr. Muna was trying to share through her QR codes. Many of you were asking, so you can actually check those in the chat.
Dr. Mira, I really appreciate your efforts and your introduction and you answering the questions. I know it's tough, but we have the mention of the using the filters by.
Sorry, I get disconnected. I'm not sure. From
Welcome
me.
back, Victoria.
Welcome back.
Yeah, sorry. طيب. Your question
We were
was
talking about the additives into the ready-made.
yes, if your patient is obese and you cannot fulfill one of the macronutrients, so it's going to be perfect if you are having supplemental parental nutrition or obese patient because obese patient they having hypocaloric feeding. I know you're not gonna fulfill the high protein requirements for 100%, but at some extent you're gonna cover that. And it's only allowed for additives to be added for the multi-chamber. I have to ask your company to provide you with a stability study for each product.
Excellent. You mentioning the filter actually provoked few questions. So do I need to use the filter for any TBN bag, for any
Yeah.
lipid emulsion?
Yes, the TPN filter, the old recommendation to have two filters. You have a TPN filter size 0.22 microgram, and the lipid filter size 1.2. The old recommendation is to have two filters, a TPN filter for the TPN bag and the lipid filter for the lipid bag. The TPN filter, the benefit of this TPN filter, it's like it's for protection for the patient because it will prevent any bacterial contamination to pass any particles, not because of calcium and phosphate precipitation. Sometimes with the preparation, it may have rubber particles inside the TPN bag. So this lipid filter will not allow any particles above the 0.2 microgram to pass this line and to pass this circulation. So it will protect your patients. And the new recommendation, the updated guidelines recommendation from the Aspen to use only one filters, the lipid filter, which is 1.2, and you need to have a Y connector to connect your lipid and the TPN. And then after the Y connection, you have your filter size 1.2 because they found
Excellent.
the particles above the 1.2 is the more dangerous. Will not pass this circulation. But this is if you have your Y connector.
Excellent. I'm trying to see all the questions because I know some centers they might not have the most updated or most optimal settings. We have a question here about if I'm dealing with a patient, but unfortunately the TBN supply is interrupted and erratic and inconsistent. So what would be the approach here? I think they're trying to see if we can use other peripheral solutions until I have a full TBN, like dextrose, for example, until I have a TBN or something.
Yes, we have a lots of product shortage. You may experience. I know it's very challenging, so I would recommend you to use the Aspen link, the parental nutrition resources. So it will give you a full direction and recommendation whenever you have any shortage from any type of nutrients. It will give you a full recommendations what to do. So in case you have a multivitamins shortage, you just prioritize your neonate and pediatric patient, and you may give once or twice a week for the rest of the patient just to minimize the consumption of the multivitamins. So it has lots of recommendation. I will just post it here in the chat.
Great. One of the questions is asking about a patient they have is on TPN following high output ECF, and 3 days into the parental nutrition, she started having chest pain difficulty with breathing, and corporeal spasm. Later, she developed irrational talks. So they're asking what would be the problem? Is it TBN related, and what should they do next?
It could be TPN related. One of it, the calcium phosphate precipitations, if they're not
Mm.
used to filter, or if they don't check for calcium and phosphate precipitations. The second thing, it may cause because of the overfeeding. If there's a huge dose of dextrose, because if your formulation having high calories, high dextrose, it's gonna be having a high CO2, and it's very hard to extubate from the ventilations. And it may affect the respiratory tract because of the over feeding. Yeah, it may be because of the TPN.
Yes, it's multifactorial. You
Yeah,
have
it's
to
multifactorial.
eliminate
They
one
have
by
to
one.
work with the respiratory therapist. Yes.
I have one question. I don't understand it actually, but the shortcut for obese people at ICU will be the same despite other health issues like end-stage renal disease. And can I use this shortcut for intubated obese patients? I don't know what they mean by shortcut. Maybe equation?
I think they mean BMI. I'm not sure. For ICU patient, they have to check the baseline weight and the range of the patient's weight, because sometimes this high weight, it's not because of obesity, because sometimes it's a fluid overload. So they need to have the history of the patient, because especially with the end-stage renal disease patient, if they did not dialyze for, or they miss any
Mm.
dialysis sessions, they may get overloaded quickly. Or if your patient is cirrhotic patients, and they may have a fluid overload. So I don't recommend to use the shortcut. I recommend you to work with your dietitian, your ICU team, and walk through the history of the patient and the weight range to understand if it's fluid or it's real obesity.
Excellent. We have here another case. He said, I'm dealing with a patient with high risk for refeeding syndrome. And I started very low electrolyte. I corrected the electrolyte peripherally, and I started with low dextrose. However, the phosphorus still drops, and I have low blood sugar. So how can I handle this one?
Yeah, it's very tough situation. Your patient is having hypoglycemia, and at the same time, you have a peripheral parenteral nutrition route, and you have a critical refeeding syndrome hypophosphatemia. This is one of the toughest cases we're dealing with. So in this case, you will just maximize your dextrose and phosphate doses, and you just do frequent monitoring every 3 or 4 hours, ABG, because one of the privilege of having patients in ICU, you have a blood gas, so no need to wait for a blood sample. So you need a frequent monitoring every 3 or every 4 hours. And of course, you will prioritize the hypoglycemia, because hypoglycemia is very dangerous. And you will give the high dextrose and high phosphate at the same time. And you do frequent monitoring. In case of hypophosphatemia, you will give a bolus. And in case of dextrose, you will give a bolus at the same time. But I would not recommend to um, increase the calories, and not to advance the calories, just to keep the same. And if you just decrease the other nutrients. And to be honest, in this tough situation, because it's considered critically unstable patients, I will not recommend to continue parenteral nutrition. I would recommend, I know the ICU physician will hate me, I would recommend to continue with dextrose infusion with high phosphate electrolyte, and correct the hypoglycemia and hypophosphatemia, and then to move to with the parenteral nutrition. Because whenever you're replacing the dextrose and replacing the hypophosphatemia, the refeeding syndrome is very nasty, and it's very tough to manage while parenteral nutrition on the board. And this refeeding may cause arrhythmia. So
Yeah. So when would you consider to stop, like discontinue the TPN right now and to hold it for the next day? Would you stop it? Would you consider that, or until there is symptomatic hypophosphatemia and from the electrolyte disturbance? Like, would you wait for the symptoms to appear or stop it preemptively?
I would recommend just to hold it for 1 day, and just check on the next day if this critical hypophosphatemia is resolved and this critical hypoglycemia is resolved.
That's great. Thank you very much, Doctora. MashaAllah, we cannot have enough of your expertise. You bringing the filters spiked a lot of questions. They're asking right now if we can use filters for 3-in-1 ready-made market available. I think they should.
Yes, for sure. Any kind of TPN, you need to have a filter on board. For
Yes.
the chamber, you're going to use the 1.2 because it contains lipid. So it's not the large particles.
I have a few questions of my own, if you allow me. Sometimes it's very difficult to assess the nutritional status with medical ICU patients. Elderly, neglected, they haven't been eating well. You know, sometimes they are not in the good mood, so they will push people around them and the caregiver. When they come to our ICU, they are at high risk for malnutrition. So we give multiple days on TPN, but it's difficult to assess the feeding status, especially we don't have pre-albumin in our institution. So how would you advise on assessment of nutritional status after starting TPN?
Okay. I'm just giving my input, and I will ask Dr. Mireille, because she's an expert dietitian, to guide us and do an insights from her side. Yeah. You know, this elderly patients, they've been having chronic malnutrition because it's been neglected, as you said, and they have a poor access to food. They don't have an family around or anyone to guide them or help them. So when they move to the ICU, so they have an acute malnutrition on top of the chronic malnutrition on board. So for sure, in this case, you're gonna start the nutrition support. If the enteral feeding can be started, it's gonna be because it's recommended as a first route, the enteral feeding by all the guidelines and all the recommendation. And then if the patient is not having the full caloric need from the enteral feedings, use the parenteral nutrition as supplemental or as exclusive. For assessment, for ICU, the pre-albumin and albumin, it's not recommended as a nutritional assessment biomarkers, because the albumin, there's lots of factors. I know the albumin, it's a visceral protein which is produced from the liver, but you cannot just have this marker to assess the patient, because the albumin, it's get affected by lots of factors, fluid assessment, the dehydration, and the overloaded patients. And it get affected by the inflammation, because the albumin, it's a negative inflammatory markers. So all the ICU patients, if you notice, you will see that they have hypoalbuminemia because of the infection and sepsis, not because of the nutrition. And this is the recent recommendation by the ASPEN, to not use the albumin per se and pre-albumin as a nutritional marker. The recommended by the European guidelines for nutrition assessment is the Nutric score or NRS scores. As I mentioned earlier in the presentation, because you know the ICU patient, they're intubated, you cannot have a proper assessment for nutrition. And I'm going to leave the floor for Dr. Mireille for her expertise.
Thank you, Dr. Mona. It's a very tricky situation, as you explained. I personally love nutritional physical assessment. I always teach my wherever I go. Recently, you know, when I was in Bahrain and I did an ICU walkthrough, and I trained the dietitians there for that. Nutritional physical examination is quite easy. Not for the first, for the first time when I introduced it to my dietitians, I always tell this story. They hated me. They thought that I'm the, like the devil coming through because, the form looks very tedious, but to a trained eye, it takes a few seconds to see it. And I always say a few things. First of all, the temporals. Second, the clavicle, the shoulder, the intraosseous, and there's a place in the calf. So it is very good to actually record this because in the absence of biochemical markers where they are not impacted, where from inflammation, from other status, from the medication, it will be good to use the nutritional physical examination. And then once there are more rigid markers available, fantastic. Because yes, we can use the GLIM guidelines. The GLIM guidelines ask three main things. One is either muscle, and very difficult. I know that it's very not unpractical to have electrodes. I mean, I love it. On a research basis, we use it. But then again, in a practical setting, it is not easy to ask every patient to have a bunch of electrodes stuck on them and then check their fat-free mass index. Involuntary weight loss, they will all have it. So that's the second one. And then the third one is, have they been eating at least 50%? So all of these indicate that they're malnourished. Fair enough. We know that. That's not a question mark. Now, the question was, Dr. Omar asked, how do you follow up and see? So that's what I would say. In the absence of these biomarkers, nutritional physical examination is very easy. It takes a few seconds. If you train yourself, the first 3 to 4 patients will take half an hour maybe. And then afterwards, then you'll say, oh, now I see what I'm looking for. It will take
Yes,
a few seconds. Highly recommend
exactly.
as time
Yeah, and
elapses.
I've seen it actually. Like the difference is 1 2 days. You see the eye socket, the temporal, the patient actually looks different. Yes, you're correct. Last question is this is one thing that I suffer with daily. Let's say a patient on TPN, and right now the patient can be given full oral feeding. However, there is CT scans, maybe another OR follow up. So the patient will stay MPO for a few hours before the CT scan, before the echo, TTE, or before going to the OR. Is that a good enough reason to stay on TPN and only give trophic feeding orally, or that's we go with like a volume-based feeding and just say the patient should take this much volume orally and calculate the missing hours the patient went to the OR or to the CT scan and increase the feeding post that.
This questions, يعني just to take, it's not justifiable to continue on parental nutrition. The situation when to taper off the parental nutrition if your energy requirements is 60% achieved by the enteral or oral feeding. So if your patient is getting 60% from his target from oral or enteral feeding, so it's no need to continue on parental nutrition. What's your opinion, Dr. Mirai?
So definitely, if the patient, I mean, I completely echo what you're saying. If the patient needs to continue on total parental nutrition, then yes, why not continue before the OR? So the OR and the route of feeding should not be, judgment for each other. It is the tolerance of the patient. Now, if the patient can tolerate oral feeding, then you stop at 60% and above, as Dr. Muna said. But you can find other ways to feed. For example, the ERAS protocol says 2 hours
Yes.
before the OR, you can give liquids, right? Like an apple juice or like clear liquid that has sugar. That can be given. So no need to, continue total parenteral, which is, you always have to think about, I mean, as I said, I think earlier, parenteral nutrition is fantastic, but it always comes with some side effects. So only let's give it to the people who truly need it. If they don't need it, then anything oral can be, a lot of things can be manipulated. Even there are some things that are high in electrolytes, like Gatorade, for example, high in sugar and electrolytes that can prevent refeeding syndrome right before the OR. That can be also given. So no need.
Yeah. I think also we should be flexible a little bit with the internal feeding rate. So if the patient is 20 ml per hour or 40 ml per hour, for example, and stop for 4 hours, we should calculate the deficit here and add it to the next as long as tolerated. right?
Add to the mix, you mean to the mix of what?
To the remaining hours of the day. If the patient went to the OR for 4 hours, for example, we should calculate the deficit in calories and then add it to the rate as long as tolerated.
If they tolerate, yes, that very often becomes the toleration becomes an issue. Yeah.
Yes, the limiting factor. Dr. Mireille, your physical examination of nutritional status is interesting, and the attendees require that you just repeat a little bit of the examination site of the malnutrition.
So it's I think four sites. The temporal, you need to look at the person. Maybe I can pull out some pictures and show maybe, but let me just say this. So the temporal is the first one. You have to make sure that it is straight and it is not scooping. If it's scooping, then it is severe malnutrition. If it's straight, then you have to look at the face from front, not from the sides. Shoulder, the shoulder is, if it is angular, you actually feel the angle of the shoulder, that is severe malnutrition. If it's becoming a bit curvy, then fat is accumulating and muscle is accumulating. That is great. Clavicle, for the clavicle for males, the clavicle should not show at all for a well-nourished patient. For a female, it can show a tiny bit. So when it is showing protrudedly for either one of them, that is severe malnutrition. And then when you go to the leg, so this is, let's say this is the knee, and right on top, the muscle, the thigh muscle, has to be kind of like a V from the inside. The inner thigh has to be like a V. Okay, that is the normal. If it's straight, then it is slight malnutrition. And if it is scooping inside the muscle, then it is severe malnutrition. So these are kind of the facts that you look into upper and lower body muscle and subcutaneous fat, and then you can identify if the patient is improving or not. But of course, when it comes to all of these, for example, for a dialysis patient, I would check them at the end of the session. And if I have somebody with pitting edema, then I would understand that, for example, the face is not a good place to check because they would be water overload. So you have to always have the clinician judgment also.
That's great. Thank you very much, Doctor. We have another question about refeeding, Dr. Amuna. If it was oral feeding or TPN, peripheral feeding, will it differ in my management in stopping the feeding, or is it the same?
It goes with the same scenario because the refeeding, because of the patient has been not receiving any kind of energy. So once you give dextrose, so the insulin will spike and may cause shifting the electrolyte inside the cells. So this refeeding is happening with any kind of dextrose intake, even oral or enteral or IV, or any kind of dextrose intake. So you will use this precaution with any type of feeding.
Dr. Omar, may I answer one of the questions? So somebody's asking, because kidney is my specialty, I have to say this. Somebody's asking, why do vitamin D levels decline as GFR decreases? Because 10% of our vitamin D that we take, if it's not the active vitamin D, is activated by the liver, 80 to 90% by the kidney. So once the kidney starts having a dysfunction, the activation of vitamin D will not be happening. That is why in these patients, we need to give them the active form of vitamin.
Yes, for sure. You need to give an active vitamin D, cholecalciferol.
The recording of the webinar will be sent to everyone. It will be posted on the website, but it will be also emailed to you with the certificates. I think we're done, Dr. Ahmad.
Thank you very much. It was a really interesting lecture and very informative. It's apparent by the number of questions and the number of gratitude we get from the attendees. Thank you, Dr. Amuna. Thank you, Dr. Mireille.
Dr. Mona, when people ask so much questions, that means that they understood your way.
This is what I'm aiming for.
Yes.
Yeah. And thank you, Dr. Mireille, for your input, and thank you, Dr. Omar, for sharing your experience and insights. I really enjoy this session because it has interactive from different angle and different specialty. Thank you so much. And alhamdulillah, we have an interesting sessions.
Alhamdulillah.
Thank you, everyone. Have a good day. Bye-bye.
Thank you.
You too. Bye.